Welcome to the Deep Dive. We're here to cut through the noise and bring you the knowledge that really matters. Today, we've got one main goal, a thorough exploration of the book, Wound Care Essentials. We want to give you a really clear picture of what this guy offers, and we'll help you decide if it's something valuable for your clinical practice library.
Yeah, and what strikes you immediately about this book is just the sheer range of expertise involved. You've got people from wound research, pediatric nursing, microbiology, and dedicated wound care specialists all contributing. That kind of multidisciplinary view is just so vital in wound management.
Absolutely. I mean, just glancing at the chapter list, the scope is huge. It goes from, the changing language in wound care all the way to managing specific ulcers, arterial, venous, diabetic foot ulcers. And then there are these big sections on things like reimbursement, legal issues with documentation, the basic science of healing,
Assessment, infection, debridement, dressings, nutrition.
pressure injuries, pain, skin tears, edema, even things like device injuries, palliative care, and atypical wounds. It really covers the waterfront.
It really does. And for this deep dive, we're zeroing in on the practical side for you, the clinician. How can what's in Wound Care Essentials actually help you in your day-to-day practice? How does it benefit your patients? That's really the core question.
Okay, so with such a packed resource, where's the best place to start to really understand its value?
Well, I think a good starting point is looking at how the field itself is moving forward, and the book captures these shifts right from the get-go, starting with terminology.
Right, that change from pressure ulcers to pressure injuries.
Well,
Seems small, but it signals a deeper understanding, doesn't it?
exactly. And the book really digs into the updated guidelines, from NPIAP, EPUAP, and PPPIA. Their third edition came out in November 2019. What's really significant there is the increased focus on medical device-related pressure injuries, MRPI, and also injuries to mucous membranes, maybe areas that didn't get as much airtime before.
That feels critical, especially with how much we rely on devices now.
Uh,
And what about kids? Have the guidelines changed for pediatric patients?
They have. The book highlights the updated Braden QD scale, that's the risk assessment tool for pediatrics. It's been validated and now specifically includes medical devices in the assessment. That's a nod to the unique risks for younger patients.
Okay. And the old 2-hour turning schedule, is the book still pushing that, or is thinking evolving there too?
It addresses the research, yeah. Wound Care Essentials points out that the evidence-based guidelines are actually starting to support potentially longer intervals, maybe up to 4 hours, if the patient is on the right kind of support surface. This isn't just opinion. It's backed by some key studies suggesting less frequent turning can be okay on the right mattress.
That's good to hear established practices getting refined by evidence. Now, something that always feels like a bit of a minefield is reimbursement and regulations. Does the book offer some help there?
Oh, definitely. There's a whole chapter on the complexities of reimbursement. It doesn't shy away from how much these rules impact who gets care and, frankly, the level of care they get. It makes the point that clinicians really need a solid grasp of these rules to deliver the best care within the system we have.
Because great clinical care involves navigating the paperwork and the finances too.
Precisely. The book looks at managed care organizations, MCOs, and points out how, their coverage for wound care can vary quite a bit, and then it hits you with the economic impact. Chronic non-healing wounds cost Medicare somewhere between, $28 and $31 billion back in 2014. That really drives home the scale of the issue.
Wow, those numbers are massive. So how does the book actually help clinicians manage this side of things?
It breaks down Medicare reimbursement into its core parts: coding, the coverage policies, and how payments actually work. And here's a key insight. Just because there's a code for something doesn't mean it's automatically covered or paid for. It gives examples like negative pressure wound therapy, NPWT. For Medicare Part B coverage, you need specific conditions met, like a chronic stage 3 or 4 pressure injury, or certain ulcer types that have been around for at least 30 days. And you need the documentation to back up why it's medically necessary.
So understanding the hoops you need to jump through and really nailing that documentation.
Absolutely. Especially for those more expensive therapies like MPWT, you have to prove medical necessity. The book also explains things like the prospective payment system, PPS, for hospital outpatient services, and the ambulatory payment classifications, APCs.
It clarifies that you get a set amount for an APC group, and that payment has to cover the wound care supplies too. Understanding that helps manage resources.
And it sounds like reimbursement is getting more tied to the quality of care you provide.
That's a huge point the book makes. Reimbursement rules are increasingly linked with quality assessment and improvement. You might not get reimbursed for substandard care. There's a growing push for value-based care. And pressure injuries are often used as a key measure for quality improvement efforts.
Right, sends a clear message. High-quality evidence-based care isn't just the right thing to do ethically, it's also increasingly vital for reimbursement. Okay, let's shift gears slightly. Legal issues. Wound care can carry some significant legal risks, right?
It definitely can. And Wound Care Essentials tackles this head on. It talks about the potential for medical malpractice claims. It lays out the 4 basic things needed for a malpractice claim. There has to be a duty of care. That duty has to be breached. There has to be an injury directly caused by that breach. And there are to be legally recognized damages.
And that duty in healthcare comes from the patient-provider relationship.
Exactly. The book explains how that relationship sets up the expectation that the patient relies on your professional knowledge and skill, which leads directly to, well, documentation again.
Which I imagine is absolutely critical if things ever go legal.
Oh, completely. The book has a really strong practice point on this. Accurate, complete documentation of outcomes and responses to treatment. That's your foundation, both for making good care decisions day to day and for defending yourself legally. It points out that wound assessments often demand some of the most detailed, time-consuming documentation you'll do.
Because it's not like reading a lab value, right?
Yeah.
It's very visual, very subjective in some ways.
Precisely. And that's where problems can creep in. The book highlights how different knowledge levels among staff, or maybe a lack of standard policies, can lead to documentation that's inaccurate, inconsistent, or just plain wrong. Plus, if you have a patient with multiple wounds, finding all the information related to just one wound can be tough if it's scattered all over the medical record. That increases the risk of missing something important.
Yeah, that makes perfect sense. Meticulous, standardized documentation isn't just good practice, it's vital risk management. Okay, let's get into the science how wounds actually heal. The book differentiates between acute and chronic wounds, right?
Yes, it does. And that chapter lays out clear objectives. Understand the physiology, the pathophysiology, the sequence of events in healing, the key differences between acute and chronic, the terminology, host factors, biofilm effects, and also the principles of wound bed preparation, the time framework. That's tissue management, inflammation, infection control, moisture balance, and edge advancement. Plus, knowing the symptoms of chronic wounds, it's a solid overview of the biology.
And it mentions cytokines and growth factors, which always seem incredibly complex.
Well, what's helpful is how the book sort of simplifies it. It explains these are signaling molecules with diverse, sometimes overlapping effects. They interact in complicated ways. It gives some examples to make it more concrete. Then, talking about the proliferation phase, when granulation tissue forms, it gives a really important practice point about the risk of wound dehiscence, the wound opening up or even evisceration in those first 3 weeks after surgery.
Which is crucial information for teaching patients and preventing those kinds of complications.
Absolutely. The book really stresses educating patients about what normal inflammation looks like versus signs of trouble and the precautions they need to take post-op. It helps them be partners in their recovery.
Okay, and what about things that can slow healing down? The book covers host factors.
Yes, a whole list. Age, other diseases the patient has, sex, race or ethnicity, their immune status, medications they're on, BMI, nutrition, lifestyle like smoking. It specifically talks about how aging impacts healing, more pro-inflammatory cytokines, fewer key growth factors. And even when growth factors are there, the cells in older patients might not respond as well. The book really flags age and nutritional status as 2 key factors you can often directly influence to boost healing.
It's a good reminder that wound care has to be personalized, considering all these patient-specific things. And then there's the whole issue of biofilms in chronic wounds.
Right. The book reflects the current understanding that biofilms are likely present in most chronic wounds. They can be on the surface, but also deeper in the tissue. It acknowledges it's hard to tell biofilm apart from slough just by looking, and explains the connection biofilms fuel inflammation, which increases exudate and slop buildup.
Which definitely complicates just looking at a wound. And I know standard cultures don't always pick up biofilms well.
That's a critical point the book makes. Standard lab tests are designed mostly for free-floating bacteria, not these complex communities stuck to surfaces. It notes that specialized microscopy is really the most reliable way to confirm biofilms right now. Understanding this is key because it changes how we approach chronic wounds, often needing strategies specifically to disrupt those biofilms.
It really highlights that we need a more sophisticated view of the microbes in chronic wounds than just what a standard culture shows. Now, assessment and documentation, again, we touched on the legal side, but it's obviously huge clinically too.
Absolutely fundamental. The book emphasizes that reliable, consistent, comprehensive, accurate wound description and documentation are essential for multiple reasons. It lets you classify the wound correctly by its cause and characteristics. That directly guides your overall medical plan and your local treatments. Plus, good documentation is how you track progress or catch deterioration early. And it improves communication among everyone involved, the whole team, the patient, different care settings.
So it's not just for the immediate team, it helps ensure continuity of care across providers and settings too.
Exactly. The book also gives a clear list of warning signs, things that might indicate a wound emergency, like new or worsening pain, cellulitis spreading, changes in drainage, whether it's pus or not, or significant undermining under the skin edge, red flags needing immediate attention.
Okay, and what does the book consider essential for a really thorough initial wound assessment?
It's pretty comprehensive. It goes beyond just the hole in the patient. You need the full medical and social history, the patient's own goals for care, factors affecting healing potential, a vascular assessment, relevant labs, nutritional status check, pain assessment. Also, risk for new wounds, their psychological and cognitive state, social and financial support, functional ability, can they redistribute pressure, what support services do they have access to, and their own knowledge about prevention and treatment.
Wow, that's a truly holistic, patient-centered view. And for the wound itself, what are the minimum must-haves in the assessment?
The essentials are a thorough overall patient check, identifying the cause of the wound, and then documenting the wound's characteristics. That means type, location, size, length, width, depth, the amount, and type of exudate, what kind of tissue you see in the wound bed, and the condition of the skin right around the wound, the peri-wound skin.
The book even gives tips on how to measure accurately.
And describing the tissue types in the wound bed is obviously key, too.
Oh, yeah. The book explains how to document granulation tissue, epithelialization, either measuring new growth or estimating percentage coverage. It defines necrotic tissue, clearly Escher, that dry, hard, black stuff, and slaw, the yellow, soft, moist stuff. It stresses documenting the type and percentage of necrotic tissue because it blocks healing and harbors bacteria. And it loops back to remind you that biofilm, even if you can't see it distinctly, is often lurking in chronic wounds too.
Okay, so accurate assessment really is the bedrock for everything else: diagnosis, treatment planning, tracking progress, and legal protection. Let's talk about managing the microbes, bioburden, and infection. The book presents these as stages. Yes, it lays out a kind of continuum: contamination, then colonization, then critical colonization, which often involves biofilm, and finally full-blown infection.
Yeah.
It clarifies that critical colonization is where you have localized microbial communities starting to mess with healing, maybe with subtle local infection signs. True infection, though, means microbes invading tissue with systemic inflammation signs: redness, heat, swelling, pain. More exudate, usually needing systemic antibiotics that hit actively dividing bacteria.
And the tricky part with chronic wounds is that those classic infection signs aren't always obvious.
Exactly. The book points out that chronic wounds often have persistent inflammation anyway, which can mask or confuse the picture. But it does note that increased pain can be a really useful clue that infection might be brewing in a chronic wound. It also acknowledges the difficulty in studying infection signs systematically because there's no perfect gold standard test tissue. Biopsy culture is best, but not always practical.
And if you do get a culture, the technique matters.
Hugely important. Wound Care Essentials recommends the Levain technique for swab cultures. That means cleaning the wound, then pressing the swab firmly enough to get fluid from the tissue itself. The goal is to sample the microbes actually in the tissue, not just the ones sitting on the surface.
The book also talks about a step-down, step-up approach for managing wounds with suspected high bioburden. Can you explain that?
Yeah, it's a dynamic strategy. You might start with a more aggressive combined approach, maybe sharp debridement to remove dead tissue and disrupt biofilm, perhaps using topical antimicrobials or antiseptics empirically, strategies to break down biofilm further, and optimizing host factors. Then you watch closely. If the wound improves, you might gradually reduce or step down the intensity of treatment. If it's not improving or gets worse, you step up with more aggressive or targeted therapies. It allows for a personalized response based on how the wound behaves.
And at that critical colonization or biofilm stage, the book emphasizes a specific type of debridement.
Yes, it highlights sharp or aggressive debridement as really essential then. You need to physically remove that devitalized tissue where the biofilm lives and disrupt the biofilm structure itself. But it also acknowledges biofilm isn't always obvious, and even surgery might not get it all. Plus, biofilm bounces back fast. It can mature again within 72 hours after debridement. That's why repeated debridement, maybe every 7 days or so, is often necessary to really manage the bioburden.
Makes sense. You're constantly trying to knock back those microbial communities before they get established enough to stop healing. Let's shift to the practical how-to of debridement. The book calls it both an art and a science.
It does. And it starts with something crucial but sometimes skipped: thorough pre-debridement teaching. Wound Care Essentials really stresses patient-centered care means explaining why you're doing it, what they could expect, what the options are, the method you chose, and potential complications, not just to the patient, but family, caregivers too. And tackling that common myth that necrotic tissue, especially dry eschar, is somehow a good sign or part of healing.
Yeah, I can imagine patients might be worried about having tissue removed or misunderstand why it's needed.
Exactly. The Buzz explains that while eschar might seem protective sometimes, for healing to actually happen, those epithelial cells need a clean, healthy granulation base to crawl across. It also prepares patients. The wound might look bigger right after debridement. You're essentially turning that chronic wound back into an acute one to jumpstart healing again.
Okay, and then the book goes through the different types of debridement available.
Yep, it covers enzymatic debridement using enzymes like collagenase to break down necrotic tissue. It notes some older products like papain-urea aren't available in the U.S. anymore. It explains autolytic debridement using the body's own enzymes in a moist environment. It's slower, often more comfortable, but not for deep or infected wounds or patients with poor circulation or nutrition. Then it briefly covers the others: mechanical, biological, using maggots, sharp or surgical, and even laser debridement. Gives you a good sense of the toolbox.
And it includes a case study to show how this works in practice.
It does. A complex diabetic foot ulcer case with a thick callus, nail issues, possible bone infection. It really walks through the clinical thinking: why choose a certain debridement method, why pick a specific dressing afterwards. In that case, a calcium alginate for bleeding control and maintaining moisture after debriding. It helps connect the theory to reality.
That practical application is so helpful. Okay, so once the wound bed is prepped, choosing the right dressing is next. The book has a really simple guiding principle here, doesn't it?
It really does, and it's powerful. If the wound is dry, add moisture. If the wound has drainage, absorb it. If the wound has necrotic tissue, debride it. It sounds basic, but it captures the core goals of local wound care and helps guide dressing choice.
And it's not just a one-time choice, right? You have to keep reassessing.
Absolutely. The book hammers this home. At every dressing change, reassess the wound. Be ready to adjust your plan and your dressing choice based on what you see. And remember to consider the whole picture: the patient, the wound itself, where it is on the body. And always use the manufacturer's info for guidance on how to use each specific dressing correctly.
Good reminder that dressing selection is an active process needing good judgment. Now, let's talk about a huge systemic factor: nutrition. The book covers this too.
Yes, and it starts by making a really important distinction between chronic starvation, where the body kind of adapts to low intake, and inflammation-related malnutrition. That second one is key in wound care. It's caused by the metabolic stress of injury, illness, infection. It cranks up energy needs and breaks down muscle mass, which seriously hinders healing and can make nutrition interventions less effective. The book points out even a 10% loss of lean body mass can suppress the immune system and increase infection risk. A 15–20% loss really delays wound healing.
And it stresses a systematic way to assess nutrition status.
Definitely. It outlines the nutrition care process, the NCP, from the Academy of Nutrition and Dietetics.
Yeah.
That's a standard framework: assessment, diagnosis, intervention, and monitoring evaluation. It highlights the vital roles of registered dietitian nutritionists, RDNs, and dietetic technicians, registered NDTRs, in using this process effectively for patients with wounds.
And are there specific nutritional targets the book recommends for wound patients?
Yes, it talks about increased calorie needs, especially for malnourished patients or those with pressure injuries, often recommending 30 to 35 kilocalories per kilogram of body weight daily to cover that hypermetabolic stress and fuel repair. It also stresses carbohydrates, especially complex ones, as the main energy source for making collagen, suggesting they should be maybe 50–60% of daily intake.
And does it cover specific groups, like babies or children?
It does. It notes that critically ill newborns and kids with wounds often have other issues making nutrition tricky. Their need for growth puts them at higher risk for pressure injuries and can slow healing. So, the book emphasizes early and frequent nutrition screening and assessment for them, aligning with international guidelines.
It's clear nutrition isn't just an extra, it's absolutely fundamental to wound care. Okay, let's focus on a major issue: pressure injuries. The book gives this a lot of attention, both prevention and management.
It really does. It starts with the basic mechanics, how body weight over bone causes pressure, leading to ischemia, then reperfusion injury when pressure's off, and direct cell damage. It highlights that ischemic damage can happen in just a couple of hours, but excessive stretching or squashing of cells can kill them in minutes, and points out that higher skin temperature makes tissue more vulnerable.
And what about using interface pressure readings to assess support surfaces? The book advises some caution there.
Exactly. It explains that tissue tolerance varies hugely between individuals. So while pressure readings can compare surfaces or postures for one person, there's no magic number that's harmful for everyone. Pressure mapping, though, gives a more visual picture of force distribution, which can be helpful for positioning and choosing surfaces.
The book also discusses how aging makes skin more prone to pressure injuries.
Yes, it lists the changes. Less moisture, less elasticity, the junction between skin layers flattens, affecting nutrient transfer, slower cell turnover, less cushioning fat, decreased sensation. All these make older skin more fragile and susceptible to pressure, shear, and friction.
Speaking of shear and friction, does it explain how those contribute, especially during moves?
It does. It explains shear stress and strain, using the example of raising the head of the bed without repositioning, how that drags tissue layers. It also talks about how the support surface itself, its friction, how much it gives horizontally, can either worsen or reduce these forces.
And while there are tons of support surfaces out there, the book says there aren't really universal performance standards.
That's right. But it points to the WOCN Society's support surface algorithm from 2015 as a really useful decision guide. It prompts you to ask key questions about the patient's needs when choosing. The book discusses different surface types like air or foam and practical things to think about before buying: ease of use, running costs, maintenance, alarms. The main message is you need to constantly evaluate if the surface matches the patient's current needs.
And it uses that Mr. P case study again with multiple issues to show how complex care can be.
Yes, that case really drives home the challenges with patients having multiple risk factors and existing wounds. It stresses the need for tailored care, not a cookie-cutter approach. That leads into discussing the MPIAP pressure injury stages. With that crucial reminder, don't use these stages for arterial, venous, diabetic ulcers, skin tears, or moisture damage.
And it covers the big 2019 EPUA-PAPIAP clinical practice guideline.
It does. Outlines its 5 main sections, highlights key updates like more on causes, implementation tips, quality indicators. It flags the guideline's specific nutrition recommendation. High protein supplements with arginine, zinc, antioxidants for malnourished patients with stage 2 or higher PIs. It emphasizes the role of PT and OT for mobility, wheelchair fitting, seating evaluations. And it discusses the shift to individualized repositioning schedules. That rigid 2-hour turn might not fit everyone or every surface. It mentions studies like Bergstrom's suggesting longer intervals might be okay on certain high-density foam mattresses. Plus, it touches on newer tech for spotting deep tissue injuries earlier.
And finally, for managing existing pressure injuries, it comes back to debridement and other therapies.
Yes. Reiterates debridement is key for removing non-viable tissue. Stresses there's no single best method. Choice depends on goals, infection status, tissue type, cost. Sharp surgical is often most effective, essential if you suspect cellulitis or sepsis. Autolytic is slower, uses the body's enzymes. And it mentions things like electrical stimulation as potential add-ons for stubborn stage 2-4 injuries that haven't responded to standard care.
Wow, the depth on pressure injuries alone sounds like it makes the book worthwhile. Let's talk about another common issue: pain. Does the book address pain management in wound care?
It certainly does. Right off the bat, it calls pain the 5th vital sign, stressing its importance. It talks about how common pain is with pressure injuries and the major impact it has on quality of life. And the core principle: you have to believe the patient's report of their pain. It covers the different pain scales, verbal, visual, numeric, and discusses the WHO 3-step ladder, originally for cancer pain, as a possible guide for non-cancer wound pain. Matching pain level to medication strengths, non-opioids for mild, low-dose opioids for moderate, stronger ones for severe. But it adds crucial cautions about terms like weak and strong opioids, emphasizing patient factors like age, other illnesses, frailty, and previous pain med history are critical.
And it stresses scheduled pain meds to prevent breakthrough pain and how to handle it if it happens.
Exactly. It explains the analgesic gap, or end-of-dose failure, when pain creeps back before the next dose is due, and how to adjust meds or timing. It also gives several really practical practice points for minimizing pain during wound care. Assess pain before you start. Use warmed, low-toxicity cleansers, specifically avoiding things like iodine or hydrogen peroxide. Use moist dressings for less painful autolytic debridement. Change dressings promptly, protect the surrounding skin, and avoid harsh tapes on fragile skin.
Those are really useful, actionable tips for everyday practice. Okay, what about skin tears? Another really common problem, especially in older adults.
Wound Care Essentials covers this too. It starts by defining contact dermatitis and the different types of moisture damage, MAS SD, like incontinence-related skin folds around stomas or wounds, and also medical adhesive injuries, RC. Then it focuses on skin tears. Notes the cause isn't always clear, but often linked to things like bumps from wheelchairs, blunt trauma, friction during transfers, falls. Mentions peak times in long-term care. It lists risk factors: impaired activity, mobility, sensation, cognition, needing help with daily activities, sensory loss, using assisted devices. And it introduces the ISTAP risk assessment pathway and prevention program as helpful tools. It also touches on general health factors increasing risk, like sensory changes, age extremes, dementia, diabetes, vascular disease, cognitive issues.
It sounds like a good overview of something that might seem minor but can cause real problems. Now, the book gets into specific wound types based on cause, starting with venous ulcers.
Yes, it explains they're common, and the root cause is venous hypertension, high pressure in the veins, not just stasis. A key takeaway is that managing the edema, the swelling, is absolutely fundamental for healing. It stresses needing a good history, physical exam including vascular checks and ABI, and non-invasive vascular tests for diagnosis. Compression therapy is the mainstay treatment, along with leg elevation and encouraging walking. It discusses different compression bandage types, elastic, inelastic, and proper application, and briefly mentions vein procedures for underlying disease.
Then it clarifies the difference between general edema and lymphedema.
Right. Often confused, but lymphedema is specifically lymphatic system dysfunction, poor drainage. Points out patients often have a bit of both, gives a quick overview of the lymphatic system capillaries up to main trunks, and outlines the clinical stages of lymphedema, from subclinical up to severe elephantiasis with major skin changes.
Okay, shifting to arterial ulcers. The focus here is on blood supply, right?
Exactly. The book talks about lower leg artery anatomy, common blockage points, stresses needing good perfusion and blood flow for healing, mentions things like blood viscosity, hematocrit. It also highlights assessing for neuropathy, which often goes along with arterial issues, uses the SAM mnemonic, sensory autonomic motor, and the monofilament test, mentions non-invasive tests like Doppler, ABPI, TCPO2, toe pressures to check circulation, explains using a handheld Doppler. For local care, gentle cleansing is key, saline or water at low pressure, 415 psi, to remove debris without harming new tissue. And notes whirlpool usually isn't recommended due to infection risk.
And then diabetic foot ulcers, a huge area of concern.
The book explains these usually happen from repetitive pressure or shear in areas where sensation is lost due to neuropathy. Discusses how diabetes changes foot mechanics, leading to deformities like the intrinsic minus foot. It introduces the University of Texas classification system looking at depth, infection, and ischemia, and contrasts it with the older Wagner system. Offloading pressure is highlighted as absolutely critical. Mentions total contact casting, TCC. Removable cast boots notes, boots might help compliance, and the idea of instant TCC. For infection, it says there's no single best antibiotic regimen, but mentions typical osteomyelitis treatment is 4-6 weeks or longer. Emphasizes topical antiseptics as useful adjuncts for bioburden, maybe less resistance risk than antibiotics. Briefly touches on surgery for healing or preventing recurrence, weighing risks and benefits.
Very practical breakdown for managing diabetic foot issues. The book revisits pressure injuries too, with some extra points.
Yes, it reminds you to always consider osteomyelitis in stage 4 PIs needing MRI and biopsy for diagnosis. Mentions controlling other infections like UTIs before any surgery. Discusses surgical flap options for repair, stressing close post-op monitoring for flat blood supply issues, watching for paleness, coolness, pain, slow refill, etc. Notes synthetic dermal templates, like Integra, as an option for exposed bone tendon, often used with NPWT, and briefly describes necrotizing fasciitis, that dangerous, fast-moving infection needing urgent surgery because antibiotics don't penetrate dead tissue well.
And it doesn't just focus on the physical, it addresses the psychological and social aspects too.
Absolutely. Lists psychological risks like depression, anxiety, poor self-image, anger issues that can hurt treatment adherence, lead to self-neglect. Mentions cognitive impairment too. Crucially, it highlights social and environmental factors. Homelessness, financial stress, lack of support, access barriers, how these impact PI development and healing. stresses assessing the patient's own motivation to stay ulcer-free, and discusses surgical repair again, emphasizing the need for thorough preoperative coordination managing infection, nutrition, bowel function, spasms, other health problems.
The book also zooms in on device-related pressure injuries, especially in kids.
Yes, points out devices are a leading cause of PIs in babies and young children, often due to difficulty turning them safely with line tubes, and maybe over-securing devices. Notes the high percentage of device-related PIs in pediatric hospitals. Lists common culprits, breathing equipment, IVs, tracks, casts, pulse oximeters, EEG leads. Discusses pediatric-specific risk scales like Braden QD and Glamorgan that include device factors. Stresses needing kid-sized pressure relief products and positioning techniques, plus age-appropriate prevention education for families.
Good to see that specific focus. What about palliative wound care?
It tackles that too. Acknowledges the different goals, maybe not healing, but comfort, quality of life, complication prevention. Notes pain and odor are often big issues. Discusses management, topical opioids, anesthetics, non-drug methods for pain, dressings like alginates, foams, silicones for odor. Also briefly mentions radiation wounds can occur during, right after, or long after therapy and are specific to the irradiated area.
And finally, it covers atypical wounds, the ones that don't fit the usual categories.
Yes, emphasizes recognizing wounds caused by something other than pressure, neuropathy, or vascular issues is key for correct diagnosis and treatment. Notes infections can cause atypical ulcers, though less common. Says therapy often combines specific treatment with good basic wound care. Mentions using EM codes for billing therapies, discusses diagnostic tools like histology, cultures, immunofluorescence, and gives examples: pyoderma gangrenosum, pathogy, sporotrichosis, Buruli ulcer, cryofibrinogenemia.
Well, we have definitely covered a massive amount of information in this deep dive into wound care essentials. It really does seem like an incredibly comprehensive resource.
It absolutely is. And what's really strong is its commitment to evidence-based practice, but always with a focus on how you actually apply it clinically. It doesn't just throw information at you, it tries to guide you on using it effectively. By covering wound care from all angles, clinical, regulatory, legal, and from different expert viewpoints, it gives a really well-rounded perspective on a complex, changing field. It helps you understand the why behind things like reimbursement and documentation needs.
So for you listening, it should be pretty clear that Wound Care Essentials offers a lot for your daily practice. From updated guidelines on pressure injuries to navigating reimbursement and legal documentation to understanding different wound causes and how to manage them. Plus that practical step-by-step guidance on assessment, debridement, dressing selection, it seems packed with actionable insights to help you provide the best care.
Which leads to a good question for you to think about. In this constantly shifting field of wound care, new guidelines, new tech, changing rules, how could having a comprehensive go-to resource like Wound Care Essentials really empower you? How could it help you consistently achieve the best patient outcomes, navigate the complexities confidently, and ultimately support both your patient's well-being and your own professional growth?
It's definitely something to consider if you're looking to seriously boost your knowledge and have a reliable reference covering the many sides of this challenging but rewarding field. Wound Care Essentials certainly looks like a very strong candidate for your bookshelf.